So good morning and welcome to the Lightning Talks Theatre at SNOMED Expo 2025. And thank you very much to Odyssey for sponsoring the Lightning Talks this year. My name is Monica Harry. I manage the content and mapping team at SNOMED International, and I'll be introducing the presenters today. The Lightning Talks take about 10 minutes, presentations that cover a topic quickly. You can follow along by picking up a headset to listen to the audio. The presenters won't take questions, but you're welcome to find them afterwards and ask any questions then. It's now my pleasure to introduce Jacqueline, oops, losing my slide. Jacqueline Singer and Alana Lane from Canadian Institute for Health Information will be presenting Developing Standards Terminology for Social Care in Support of Connected Care in Canada. Jacqueline and Anna, over to you.
Thank you very much. We can hear? Awesome, thank you. Good morning, everyone. We are really happy to be here today to share the work that we're doing to develop standard terminology for social care in Canada. Before we get started, I want to acknowledge that this work is really the result of a whole team back in Canada. So while Alana and I have the privilege of being here at the SNOMED Expo, I want to give special acknowledgement to some key team members, including Jennifer Lawson, Brooke Harvey, and Jose Mignon. So a bit about us, briefly. We're from the Canadian Institute for Health Information, which is a national source of comparable health data that can be used to inform health policy, provide direct patient care insights, as well as management of the healthcare system and research. We develop data standards, classifications and terminologies products, as well as comprehensive reporting and analysis on the health system. The goal in all of this is to improve healthcare for Canadians. One of the key programs that we're working on is Connected Care. And the goal of this is really all about information flow, allowing a person's health information to securely flow with them throughout the healthcare system. And to do this, data standards are absolutely necessary. So the goal of this is to develop person-centric common data standards and data architecture to allow that data to move throughout the health systems while maintaining their meaning. The Pan-Canadian Health Data Content Framework is a comprehensive data standard that is sector agnostic, so relevant to all care settings, and applies to every jurisdiction in Canada. It includes data elements, value sets, and the common data architecture, including information models and logical data models. The Canadian Core Data for Interoperability, or the CACDI, is a subset of the broader Pan-Canadian Health Data Content Framework and focuses really on that minimum data that clinicians require to be shared to reduce the risk of patient harm. Within the development of these data standards, one of the key priorities is developing data and terminology standards for social care. Within the context of this presentation, when we're talking about social care, we're referring to what we more commonly know as the social determinants of health, so things like housing stability, and health behaviors, so things like substance use. These are catching up to other data standards that are more well established generally, so things like medication, and allergies. And the social care data standards are really important because they are needed to implement systemic changes that can advance health equity, while health behaviors data is really important to allow that more holistic view of a person's health that is needed to target prevention, risk management, and tailored interventions. And so we're developing these data standards, including data elements, value sets, and logical data models. In terms of the terminology development, we are following international best practices, so as much as possible aiming to reuse existing terminology where possible, or possibly adapt from other published standards while ensuring that the Canadian context is represented. In some cases, we're developing new terminology and value sets where gaps exist. We are guided by the Gravity Project based in the US, and within Canada, what's known as the SPARK tool, which is a screening and assessment tool for poverty and related social determinants to improve knowledge and access to resources. We're also guided by NICTIS in the Netherlands and other national core data for interoperability like the US and Australia. Throughout this, we are leveraging the Canadian extensions of SNOMED as well as LOINC and ensuring that the data standards are HL7 fire conformant, while noting that the data standards are technology agnostic. Throughout the development process, we're following principles of co-design, so working with a variety of groups, such as those with technical and terminological expertise, which includes people like clinicians, policymakers, researchers, patient partners, and representatives from different levels of government.
Thank you. To build on what Jacqueline said, to strengthen our data standardization and interoperability, we performed a gap analysis between the terminology that was found in the Spark tool to what was available in SNOMED CT. We wanted to ensure that the data exchange was consistent across the systems, and our key focus was usability, making sure that the terms that the clinician saw at point of care were actually clear and mutually exclusive. We looked for exact matches, and we looked to where terms were missing in SNOMED CT, so identifying those gaps. And the finding of what we found in the gap analysis supported new content development in the SNOMED CT CA edition. The housing survey questions is an example from the Spark tool. And the questions and responses from the Spark tool were the basis of our gap analysis, where we took those responses and we treated each one as a data element that could be standardized. And this table shows the analysis that we did mapping from the responses in the Spark tool to SNOMED CT. And we did find some matches, but in some cases, the available SNOMED CT terms that were there didn't quite capture the intent of the Spark response. And that's where we identified and proposed new concepts and or synonyms for those responses. And the ultimate goal was to have those unambiguous terms that support that true semantic interoperability across the health and social data. So these new proposed terms that you see here are still in draft form, and they're currently under review. For data content standard development, we looked at tobacco use status specifically. For this standard, we added new terms for tobacco use versus user to make the terminology less stigmatizing. We wanted to ensure that the SNOMED CT concepts that were available were both technically accurate and also sensitive to how the information would be discussed between the physician at point of care and with the patient. We work very closely with our NRC, Canada Health InfoAid, to fulfill the Canadian content requirements in SNOMED CT, our national edition. The promotion of these terms that we have identified to the international release will help strengthen coverage in the social and health behavior domains so that the entire SNOMED CT community can benefit. All of the value sets that are developed by CIHI that support the Pan-Canadian Health Data Framework are available in both English and Canadian French and are published on Canada Health InfoAid's terminology server. And this collaboration ensures easier access to bilingual standardized terminology in Canada. I'll pass it back to Jacqueline. There you go.
So where are we now and what's next? Just a few short weeks ago, we released our national data standard, which includes data categories ranging from medication, immunization, and procedures, as well as some social determinants of health and health behaviors draft terminology content. So this includes socio-demographic data elements like race, indigenous identity, gender, sex, and sexual orientation, service language, as well as draft value sets for social determinants of health data elements like housing stability and education attainment and others. We also have draft health behaviors risk assessment domains like tobacco, vaping, alcohol, and other substance use. So what's next for us? We are working to expand the scope of our national data standard to other domains like clinical tests, devices, lab, as well as dive deeper into the development of those social determinants of health and health behaviors data elements to new areas like sexual activity, exercise, sleep, and nutrition. And also consider the full arc, ranging from diagnosis to patient goals and interventions. So coming back to our why, the key in all of this connected care is information flow. So working with a variety of partners, keeping to the principles of co-design, as well as public and private partnerships, working with vendors and others to ensure that these standards are implemented and can help ultimately improve patient care, as well as economic benefits. So with that, thank you very much. If anybody has any questions or is doing similar work, we'd love to hear from you. Don't hesitate to come ask us questions or connect after the session or online. Thank you very much.
Thank you.
Thank you, Jacqueline and Anna. Alana, sorry. Anna, sounds similar. Yeah. Thank you, that was excellent.